Ever felt like navigating the world of cholesterol, statins, and heart health is like trying to find your way through, I don't know, a dense forest with just a flickering flashlight?
Yeah, it really can feel that way.
You hear whispers about, the dangers of butter, the magic of exercise, and the necessity of pills, and it's genuinely hard to distinguish between life-saving facts and, well, just distracting noise. The sheer volume of information, and it's often conflicting, they could leave anyone feeling pretty overwhelmed.
Absolutely. Sorting through it all is a challenge.
Today, we're not just entering that forest, we're bringing in the heavy machinery, armed with a stack of the latest research, clinical guidelines, and patient decision aids.
Okay.
Our mission in this deep dive is to unpack the most crucial insights on managing high cholesterol.
Right.
We'll decipher how treatments like statins truly work, explore the promising new frontier of alternative and adjunct therapies, and ultimately empower you with the comprehensive knowledge to actively shape and safeguard your heart's future.
That's right. We're going to pull back the curtain on everything, from the fundamental, often misunderstood role of cholesterol in your body to the intricate nuances of modern risk assessment tools, things like the QRAS calculator and, the latest ACE guidelines. We'll meticulously examine the incredible yet frequently underestimated power of lifestyle adjustments, carefully weigh the profound benefits against the potential concerns of statins, and illuminate a growing array of newer medications and even specific supplements that are playing an increasingly vital role in personalized care.
Right.
What's truly fascinating here is just how much the science has evolved, giving us an ever-expanding toolkit for, precision heart health.
Okay, let's unpack this concept that sits at the very core of our discussion.
Yeah.
Cholesterol. We've all been sort of conditioned to hear high cholesterol and immediately think bad, right? Like it's synonymous with heart disease.
Exactly. That's the immediate reaction.
But as our sources consistently reveal, it's far from that simple, isn't it?
Not at all.
It's almost like hearing fat and assuming all fat is unhealthy when we know our bodies actually need certain fats to function. Cholesterol seems to fall into a similar category, a substance with an often undeserved bad rap that is in fact absolutely essential for life.
Precisely. To clarify, cholesterol it's also a precursor for producing vital hormones like estrogen, testosterone, and cortisol, as well as vitamin D. The key distinction, as you alluded to, isn't just about cholesterol itself, but between the different types of lipoproteins that transport cholesterol in your blood and, how they behave.
And that's where the famous, almost iconic good and bad cholesterol come in, right?
Yes, exactly.
It's an analogy many of us have heard, but to really understand the implications, it helps to maybe refresh our understanding of their distinct roles.
Yes, that distinction is absolutely critical. We're talking about lipoproteins, which are essentially tiny packages made of fat and protein that transport cholesterol through your bloodstream.
Like little delivery trucks.
Kind of, yeah. High-density lipoprotein, or HDL, is often dubbed good cholesterol because it acts like your body's dedicated cleanup crew. HDL travels through your bloodstream, actively scavenging and picking up excess cholesterol from cells and artery walls, transporting it back to the liver for reprocessing or removal from the body.
Okay, so it takes the trash out.
Basically, yes. So higher HDL levels are generally protective, as they help clear cholesterol from where it shouldn't be. On the other side, low-density lipoprotein, or LDL, is the infamous bad cholesterol.
The villain of the story.
Often painted that way, yes. Think of LDL as the delivery truck that, when there are too many of them or they're overloaded, starts dropping off their cargo in all the wrong places. In excess, LDL particles can penetrate the lining of your artery walls. They then become oxidized, which triggers an inflammatory response. This process is the primary initiator of plaque buildup, making LDL the central culprit in that arterial traffic jam we mentioned.
And that buildup, those insidious fatty deposits that start to accumulate, that's where the real trouble begins, isn't it?
That's exactly right.
It's not just a minor annoyance. It's a silent, progressive process that can creep along for years, ultimately leading to some very serious and often life-threatening cardiovascular crises. We're talking about much more than just a little blockage here and there.
Indeed. This insidious process, often referred to as the silent killer, is called atherosclerosis. It's a chronic inflammatory disease where cholesterol, particularly that oxidized LDL, plus fat and other substances, including cellular waste products, calcium, and fibrin, form these hard, sticky plaques within the inner walls of your arteries.
Like scale inside a pipe.
Very much like that. These plaques cause the arteries to stiffen and narrow. This narrowing significantly reduces the vital blood flow to your organs and tissues.
Okay.
What's particularly concerning is that atherosclerosis can advance for years, sometimes decades, without any noticeable symptoms.
That's the scary part.
It is. This is precisely why we refer to high cholesterol as a silent threat. You might not feel anything until an artery is significantly blocked, or worse, until one of these plaques becomes unstable, ruptures, and triggers a blood clot.
And the consequences of that plaque buildup are truly severe, impacting pretty much every major organ system. We're not just talking about minor inconveniences. These are life-altering, often catastrophic events. When we look at what happens, we see
Well, you have heart attacks, right? That occurs when a blood clot completely blocks the blood supply to a section of the heart muscle, often triggered by a ruptured plaque. Without oxygen, heart muscle cells begin to die, causing permanent damage and potentially leading to heart failure or even sudden cardiac death.
That's terrifying.
It is. Then there's angina. This manifests as crushing chest pain or discomfort, maybe radiating to the arm, neck, jaw, or back, and it's a direct signal that the heart muscle isn't receiving enough oxygen due to those narrowed arteries.
The warning sign.
A critical warning sign, exactly. While not a heart attack itself, it signals the heart is under stress. Then you have stroke. This happens when the blood supply to part of the brain is cut off, either by a clot blocking an artery or by a ruptured blood vessel.
Okay.
If caused by atherosclerosis, it's often a clot formed from a dislodged plaque in the carotid arteries. Those are in the neck or within the brain itself. This can lead to long-term disability, speech impairment, paralysis.
Devastating effects.
Truly. And related to that is a transient ischemic attack, TIA, often called a mini-stroke. A TIA is caused by a temporary, short-lived interruption in blood supply to the brain. While symptoms resolve quickly, it's a crucial warning sign that a full-blown stroke could be imminent, signaling underlying atherosclerosis.
So don't ignore a TIA.
Never. And finally, there's peripheral artery disease, PAD. This condition affects arteries supplying blood to the limbs, most commonly the legs. Narrowed arteries cause pain, numbness, or cramping in the legs and feet, especially during exercise, and can lead to severe complications like ulcers and even amputation if blood flow is critically impaired.
Wow. Okay, so these aren't just minor inconveniences. They require urgent medical treatment and can lead to long-term health problems and disability, fundamentally altering a person's quality of life.
Absolutely.
So understanding your cholesterol numbers is a crucial first step because early detection and proactive management can literally be a lifesaver, preventing these devastating events from ever occurring.
Absolutely. Given that high cholesterol rarely causes symptoms on its own, making it extremely difficult to detect without proper testing, a simple lipid profile blood test becomes our most powerful diagnostic tool.
Right.
This test, which usually requires an 8 to 12-hour fast to get accurate triglyceride readings, gives us a comprehensive snapshot of your cholesterol levels and helps assess your individual risk. It's a proactive measure that empowers you with critical information.
And for adults 20 and over, the CDC recommends we keep a close eye on a few key numbers. These are the sort of benchmarks to aim for, right?
Yes, these are the general targets.
First, HDL, high-density lipoprotein.
Right.
For our good cholesterol, a healthy level is 50 milli-GDL or higher for women and 40 milli-GDL or higher for men. The higher the better for that cleanup crew.
Correct. Higher is better for HDL.
Then LDL, low-density lipoprotein. For the bad cholesterol, we ideally want to see it less than 100 milli-GDL. Although for those with existing heart disease or very high risk, even lower targets might be recommended by your doctor.
That's right. The target can be much lower depending on individual risk. Less than 100 is a general goal for many healthy adults.
Okay, then total cholesterol. This includes both your HDL and LDL, along with 20% of your triglyceride value.
Mm-hmm.
The healthy range for total cholesterol is generally 125 to 200 milli-GDL.
Mm-hmm.
And finally, triglycerides. These are another type of fat in your blood, and a healthy level is less than 150 milli-GDL.
Right, and triglyceride levels are often higher in people with high cholesterol, existing heart problems, obesity, or diabetes, and high levels are an independent risk factor for cardiovascular disease.
Got it. The CDC recommends that most healthy adults get these levels checked every 4 to 6 years, or more often if you have existing risk factors like high blood pressure, diabetes, or a strong family history of high cholesterol or early heart disease.
Yes, frequency depends on risk.
Because genetic factors, as we'll touch on, can play a significant role regardless of your lifestyle.
Absolutely. Genetics can be a major player.
Okay, before we even delve into the world of medications, our sources make it abundantly clear. Lifestyle changes are not just supplementary advice. They are Powerful, foundational interventions.
Absolutely fundamental.
They're often the first line of defense, capable of significantly altering your cholesterol profile, and they can even amplify the effectiveness of medication if you end up needing it.
They work synergistically.
It's truly amazing how much control and positive influence we have over our own health trajectory just through our daily conscious choices.
It really is empowering. This raises an important question, though. What tangible, doable steps can you take right now without needing a prescription to influence your cholesterol levels in a meaningful way?
Yeah, what actually works?
Our sources provide clear, actionable advice, emphasizing that these aren't extreme overhauls, but rather consistent, smart choices that compound over time. The surprising truth isn't about grand gestures, but the compounding power of micro-habits.
Small steps add up.
Exactly. Consistent, small dietary tweaks and bursts of activity can, over time, rival the impact of significant medical interventions for some individuals.
It's not about deprivation. It's about smart swaps, mindful portions, and actively adding nutrient-rich foods to your plate.
Precisely.
Think of your arteries like the intricate water pipes in your home. You absolutely don't want sticky grease, calcium, and debris building up in them, narrowing the flow.
Good analogy.
You want clear, smooth flow day in and day out, and what you eat plays an enormous foundational role in maintaining that optimal circulation.
Exactly. When it comes to dietary adjustments for a healthier heart, the scientific consensus is clear and actionable. First, reduce saturated fats.
Okay, where do we find those mainly?
Primarily found in red meat, processed meats like bacon and sausages, and full-fat dairy products such as butter and cheese. These directly increase your bad LDL cholesterol. The American Heart Association recommends limiting saturated fat to no more than 5–6% of your total daily calories. A simple swap. Choose leaner cuts of meat, opt for low-fat dairy, or incorporate more plant-based protein sources like legumes.
Makes sense. What else?
Second, eliminate trans fats. These are the real villains, often lurking in margarines, store-bought cookies, crackers, cakes, and many fried or processed foods.
They used to be labeled partially hydrogenated vegetable oil, right?
Exactly. Trans fats uniquely increase your LDL and decrease your good HDL cholesterol, a double whammy for heart health.
Ugh.
The good news is the FDA banned their widespread use by January 1st, 2021. So many products no longer contain them, but awareness is still key for older products, maybe certain restaurant foods or items imported from countries with different regulations. Always check labels.
Good tip. Keep checking those labels.
Third, embrace omega-3 fatty acids. While they don't directly impact LDL cholesterol much, they offer a host of other profound heart benefits.
Like what?
Omega-3s are powerful anti-inflammatory agents. They can reduce triglyceride levels and they help lower blood pressure. You'll find them abundantly in fatty fish like salmon, mackerel, and herring.
And plant sources.
For plant-based sources, walnuts, flax seeds, and chia seeds are excellent. Aim for at least 2 servings of fatty fish per week, or discuss supplements with your doctor.
Okay, what's next?
Fourth, increase soluble fiber. This is a true unsung hero.
Soluble fiber, like in oatmeal.
Exactly. Oatmeal, kidney beans, Brussels sprouts, apples, pears, barley foods, rich in soluble fiber work by binding with bile acids in your digestive tract. Your liver then has to pull more cholesterol from your bloodstream to make new bile acids, effectively reducing your circulating cholesterol.
Clever. Like a natural cleanup.
Kind of like a natural broom, yeah, sweeping cholesterol out of your system before it can be absorbed or recirculated. Aim for 5–10 grams of soluble fiber daily.
Okay, 5–10 grams. Got it. Anything else on the diet front?
One more thing to consider, whey protein. Found in dairy products and available as a supplement, studies have shown that whey protein can be quite beneficial. It can lower both total and bad LDL cholesterol and even help reduce blood pressure.
Interesting. Easy to add to a smoothie.
Very easy, yeah. It offers a palatable way to support your heart. Now, beyond the plate, physical activity is a foundational game changer for your heart health.
Right. Exercise.
It offers direct and measurable benefits for your lipid profile. Moderate exercise can actively help raise your good HDL cholesterol, improving that crucial cleanup crew we talked about earlier.
So it boosts the good guys.
Exactly. It's not just about burning calories or getting fit. It's about improving your lipid profile directly, strengthening your heart muscle, and enhancing the flexibility of your blood vessels.
And the really good news is you don't have to become a marathon runner overnight or suddenly join, I don't know, an Olympic training team.
Not at all. That's a common misconception.
The sources suggest aiming for at least 30 minutes of moderate intensity activity 5 times a week, or 20 minutes of vigorous aerobic activity 3 times a week. That's enough to make a significant difference.
That's the general guideline, yes. And always get your doctor's okay before starting any new intense routine, of course.
Of course. But here's the kicker. Small, consistent changes really do add up. Think about practical, doable shifts.
Like what, for example?
Well, you could incorporate walking. Take a brisk daily walk during your lunch hour instead of sitting at your desk. Or if you use public transport, maybe get off one stop earlier and walk the rest of the way.
Simple but effective.
Or active commuting. If feasible, consider riding your bike to work or for errands, recreational sports. Re-engage with a favorite sport like tennis, basketball, swimming, or try something new like dancing.
Makes it fun.
Exactly. Stair power. Use the stairs instead of elevators or escalators whenever possible. Park further away. A simple trick to add a few extra steps. And increase standing activities. Things like cooking, doing yard work, or even standing at a standing desk for part of your workday can make a difference.
Every little bit helps.
Find an exercise buddy, join a walking group, or sign up for a fun class. Anything to keep that motivation burning bright. Making physical activity enjoyable and social is half the battle for long-term adherence.
Absolutely. Social support is key. Now, another major lifestyle factor. Quitting smoking.
Ah, yes, the big one.
Quitting smoking is undoubtedly one of the single most impactful decisions you can make for your heart health, perhaps even more so than any other lifestyle change. The benefits are not only profound, but also almost instantaneous, continuing to grow significantly over time.
Wow, instantaneous.
Pretty much. It's a clear, powerful step that your cardiovascular system will thank you for immediately.
And the timeline of those benefits is truly incredible, a testament to the body's remarkable ability to heal.
It really is. Within 20 minutes, your blood pressure and heart rate, which are elevated with every cigarette, begin to recover and return to a more normal level. That's almost immediate relief.
Amazing.
Within 12 hours. The carbon monoxide level in your blood drops to normal, increasing your blood's oxygen carrying capacity. Within 2 to 12 weeks, your circulation and lung function begin to improve dramatically, making everyday activities easier, reducing shortness of breath.
Significant changes quickly.
Very quickly. Within 1 year, your risk of heart disease is cut in half compared to a smoker. Think about that, a 50% reduction in just 1 year.
That's huge.
Within 5 to 15 years, your risk of stroke falls to that of a non-smoker. Within 10 years, your risk of lung cancer is about half that of a smoker, and your risk of a heart attack falls to that of someone who has never smoked.
These are truly profound benefits, illustrating the immense power of choice when it comes to your health.
Definitely. Beyond smoking cessation, managing your weight is another critical component in the fight against high cholesterol.
Right, weight management.
Even carrying a few extra pounds, particularly around the abdomen, contributes to higher bad LDL cholesterol and triglyceride levels, while often lowering good HDL.
So that belly fat is particularly risky.
It seems to be, yes. Simple, achievable changes can indeed make a significant difference. For instance, swapping sugary drinks, which are often empty calories, for water or unsweetened tea.
Easy swap.
Or, instead of reaching for high-fat snacks, opt for air-popped popcorn, a handful of unsalted nuts, or fresh fruit. These small adjustments, consistently applied, can lead to sustainable weight management and improved lipid profiles.
Okay. And what about alcohol? That's always a tricky one.
It is alcohol. This is a topic that often comes with conflicting messages. Our sources indicate that moderate alcohol use has been linked to a slight increase in good HDL cholesterol.
Ah, so there might be some benefit.
Possibly, but it's absolutely crucial to stress that this is not a recommendation for non-drinkers to start consuming alcohol for heart health.
Right, definitely not a reason to start drinking.
Exactly. The potential benefits are minor and often outweighed by the risks. For those who do drink, moderation is key. That means up to 1 drink a day for women of all ages and men over 65, and up to 2 drinks a day for men 65 and younger.
Okay, that's the definition of moderation.
Yes. Consuming too much alcohol can lead to a cascade of serious health problems, including elevated triglyceride levels, high blood pressure, and increased risk of heart failure and stroke, directly counteracting any potential, albeit minor, benefits.
Okay, here's where it gets really interesting. Diving into a class of medications that have been a cornerstone of cardiovascular prevention for decades. Statins.
The big topic.
They're often hailed as the gold standard for cholesterol lowering, and our sources delve deep into precisely why they've earned that reputation. It feels like they've been around forever, yet there's still so much conversation and even, controversy surrounding them.
There is a lot of discussion, true. The data on statins, however, seems almost unbelievably consistent across studies.
That's what I've seen.
Indeed, statins, medically known as HMG-CoA reductase inhibitors, are powerful medications introduced back in the late 1980s. To truly understand their efficacy, we need to look at their mechanism.
Okay, how do they actually work?
Think of HMG-CoA reductase as the master key enzyme in your liver's cholesterol factory. It controls the rate-limiting step in cholesterol synthesis.
The main switch, basically.
Kind of, yeah. Statins essentially jam that key, inhibiting this crucial enzyme. This biochemical intervention significantly reduces the amount of cholesterol the liver produces internally.
So it cuts down production.
Exactly. As a direct consequence, the liver then senses a shortage and upregulates its LDL receptors. Think of them as docking stations on the liver surface. This prompts it to pull more bad LDL cholesterol directly from the bloodstream to fill the gap, effectively lowering circulating levels.
So it's a two-pronged attack.
Yeah.
Less production, more removal.
Precisely. That two-pronged action is what makes them so remarkably effective.
But their benefits extend beyond simply lowering a number on a blood test, don't they? It's not just about a single measurement. They seem to have broader protective actions, what some refer to as pleiotropic effects.
That's absolutely right. Their benefits, these pleiotropic effects, extend significantly beyond simple cholesterol reduction. Statins have been shown to stabilize existing atherosclerotic plaques within the artery walls.
Stabilize them. How?
By reducing inflammation and altering plaque composition, they make these plaques less prone to rupture, which, as we discussed, is a common trigger for heart attacks and strokes.
So they make the existing damage less dangerous.
In a way, yes. They can also inhibit the proliferation of smooth muscle cells in the arteries and reduce the oxidation of LDL, both of which contribute to plaque progression. Furthermore, they offer non-cholesterol benefits, such as potent anti-inflammatory effects that calm the chronic inflammation underlying atherosclerosis.
Inflammation is a big factor in heart disease, right?
A huge factor. And they also have antioxidant effects that combat oxidative stress. They can even improve endothelial function, which is the health of the inner lining of your blood vessels. All these actions contribute to a broader protective umbrella for cardiovascular health.
Wow, okay, so quite a range of benefits. Our sources consistently highlight just how incredibly well-researched statins are.
Oh, definitely.
They're not a new kid on the block. There are decades of rigorous data and real-world experience backing them up, which seems pretty rare for many medications.
They are, in fact, among the most extensively studied cardiovascular medications in medical history, with an unparalleled abundance of research validating their effectiveness.
Just how effective are we talking?
Clinical trials involving hundreds of thousands of patients consistently show they can lower LDL cholesterol by 30% to 50%, depending on the specific statin and the dose.
That's a big drop.
It is. More importantly, this reduction translates directly into tangible, life-saving outcomes. Research confirms their ability to reduce hard endpoints, things like death from cardiovascular causes, heart attack, and stroke across incredibly diverse patient groups.
So not just in one specific type of person.
No, across the board. People with genetic high cholesterol, those with multiple risk factors but no prior events, and crucially, those who've already had a cardiovascular event and are at high risk for another. The benefits are durable, reproducible across different populations, and have fundamentally changed the landscape of preventive cardiology.
Makes sense why they're called the gold standard then.
It does. This makes them a uniquely well-understood and reliable tool.
So who actually needs to think about taking a statin? It's clearly not a one-size-fits-all answer, is it?
Definitely not.
It seems like it's a deeply personal decision, something that demands a thoughtful conversation with your doctor, not just a directive based on one number.
Not at all. The decision to initiate statin therapy is highly personalized, moving far beyond just a single cholesterol number. Modern guidelines from organizations like the American Heart Association, AHA, American College of Cardiology, ACC, and the U.S. Preventive Services Task Force, USPSTF, increasingly focus on your overall cardiovascular risk rather than just isolated lipid values.
Oh, looking at the whole picture.
Exactly. It's about looking at the full, intricate picture of your health, your lifestyle, and your individual risk factors. There are generally 4 key risk categories where statin consideration becomes paramount: based on current clinical guidelines.
Okay, what are those categories?
1. Established clinical atherosclerotic cardiovascular disease, ASCVD. If you already have a history of clinical ASCVD that includes a personal history of stroke, heart attack, peripheral vascular disease, or angina, statins are almost always recommended, assuming you can tolerate them. These individuals are at the highest risk for future events.
Okay, so if you've already had an event, it's pretty clear-cut.
Generally, yes. 2. Severe LDL cholesterol elevation. For those with extreme elevations in cholesterol, specifically an LDL cholesterol level of 190 mg/dL or higher, a statin is typically strongly recommended regardless of other risk factors. This often indicates a genetic predisposition, like familial hypercholesterolemia.
So really high numbers trigger it.
Correct. 3. Diabetes and age 40-75. If you are between 40 and 75 years old and have diabetes, either type 1 or type 2, with an LDL cholesterol level of 70 mg/dL or higher, statin therapy is generally advised. Diabetes is a powerful independent risk factor for ASCVD.
Right, diabetes significantly increases risk.
It does. And 4. High estimated 10-year ASCVD risk, age 40-75. If you are also between 40-75 years old and have a high estimated risk, generally defined as 7.5% or greater 10-year ASCVD risk by AHCC, or 10% for the USPSTF guidelines of developing heart disease or stroke, and an LDL cholesterol level of 70 mg/dL or higher, then a statin would be a strong consideration.
And that's where the risk calculators come in.
Exactly. This category is where personalized risk assessment tools become crucial.
A tool like the Cure-esque calculator, which is commonly used in the UK, or the ASCVD risk estimator in the US, can be incredibly helpful here, right? It gives you a tangible number to work with, which can feel less abstract than just being told you're high risk.
Absolutely. Your healthcare professional can use these sophisticated tools like Cure-esque to estimate your 10-year risk of experiencing a major cardiovascular event like a heart attack or stroke. It's a comprehensive calculator that considers numerous individualized factors: your age, sex, ethnicity, height, weight, blood pressure, cholesterol levels, smoking status, and whether you have conditions like diabetes or rheumatoid arthritis.
It pulls a lot of data together.
It does. The tool then calculates a percentage, which can be quite illuminating. For example, a 20% risk means that, based on your current health profile, there's a 20% chance that out of 100 people just like you, 20 would likely experience a heart event in the next decade.
Okay, that makes it concrete.
It does, but it's important to remember it's a guide, a statistical probability, not a crystal ball. And it won't account for everything, like maybe a particularly strong family history not directly tied to a calculable risk factor. This highlights the absolute importance of an in-depth, personalized discussion with your doctor, using the score as a starting point.
So it's clearly more than just a number generated by a calculator. Family history, for example, is huge.
Absolutely huge.
You can have all the right numbers on paper, but if heart disease runs deep in your family, with parents or siblings experiencing early events, that surely changes the equation and increases your personal risk profile significantly.
Precisely. The calculator is an invaluable starting point, providing a statistical framework, but it is never the final word. Clinicians consistently emphasize the necessity of discussing factors not fully captured by these algorithms or those that might amplify risk.
Like what kind of factors?
This includes a strong family history of premature heart disease, for example, a first-degree male relative under 55, or female relative under 65 who had a heart attack or stroke. Also, your current smoking status, significant weight gain, persistently high blood sugar levels, even if not yet diabetic, and undiagnosed or poorly controlled hypertension. These elements can profoundly alter your individual risk profile.
So the conversation adds layers the calculator misses.
Exactly. Sometimes, to gain an even clearer picture, additional non-invasive tests are employed, such as a coronary artery calcium or tox score test. This CT scan measures the amount of calcified plaque in your coronary arteries, providing a more direct, visual look at the extent of atherosclerosis.
Ah, so you can actually see the plaque buildup.
You can. These insights from both clinical discussion and advanced testing help in making a truly personalized and informed decision.
It's always reassuring to know that the science is evolving and new guidelines are constantly being developed and refined.
It's a dynamic field.
It demonstrates that the medical community is not static. It's always actively refining its approach based on the latest evidence, seeking to improve patient outcomes.
Indeed. The continuous evolution of medical knowledge is crucial. The 2025 AACE, that's the American Association of Clinical Endocrinologists, clinical practice guideline for the pharmacologic management of adults with dyslipidemia, is a prime example of this ongoing scientific refinement.
Okay.
Developed by a multidisciplinary task force, it uses the rigorous GRADE framework, grading of recommendations, assessment, development, and evaluation.
GRADE framework, what does that mean for patients?
Well, the GRADE framework isn't just medical jargon. It means these recommendations are meticulously built on the strongest available evidence, systematically weighing both the benefits and potential harms of specific treatments. This ensures that treatment goals are not just clinically sound, but also genuinely align with outcomes that are most important to patients in their daily lives.
So focused on what matters to people.
Exactly. For you, the listener, this means that these guidelines are designed to be comprehensive, transparent, and patient-centered, providing the most up-to-date and robust advice available.
Okay, let's talk about the elephant in the room that often looms large in discussions about statins: side effects.
Right, the big concern for many.
Many people are understandably hesitant, driven by anecdotal stories from friends and family, online forums, or even, exaggerated reports in the media. But our sources offer some crucial perspective that might help clear the air a bit and provide more balanced understanding.
This is precisely where critical thinking is absolutely essential. While statins, like all medications, can have side effects, no drug is entirely without risk. Understanding the actual incidence, severity, and effective management of these effects is key to making an informed and rational decision.
It's easy to focus on the scary stories.
It is. It's incredibly easy for rare or mild side effects to become amplified or exaggerated in public discourse, leading to unnecessary apprehension or the avoidance of potentially life-saving therapy. We need to distinguish between perception and reality.
Okay, so let's tackle the big one first. Muscle pain, or myalgia. This is the one I hear about most often. Friends, family, online forums, everyone seems to talk about statin-induced muscle aches. Is it really as common and severe as some people fear, or is there more to the story?
It is certainly the most commonly reported side effect, often referred to as statin-associated muscle symptoms, or SAMS. Documented rates in clinical trials range from 1% to 10% of patients.
Okay, 1 to 10%. That seems manageable.
Well, some observational studies and patient surveys suggest it could be as high as 10–15%. However, this is also where we see the nocebo effect come into play.
Nocebo, like the opposite of placebo.
Exactly. The nocebo effect is the less famous but equally powerful counterpart to the placebo effect. It's when your negative expectations about a treatment can actually cause you to experience side effects, even if the drug itself isn't directly responsible through its chemical action.
So if you expect muscle pain, you might actually feel it.
In a very real way, yes. If you go into statin therapy convinced you'll get muscle pain because you read about it online, your brain can manifest that sensation. Rigorous, double-blind trials, where neither the patient nor the doctor knows if they're getting the statin or a placebo, often show the true incidence directly attributable to the statin might be closer to 5% or even lower.
Wow. That highlights the power of the mind.
It really does. It underlines why open, informed discussion with your doctor, free from external biases, is so crucial. Now, typically, when muscle pain does occur due to statins, it's mild, often presents as aching or weakness, usually affecting larger muscle groups like the thighs or calves.
And is it permanent?
No, importantly, it's fully reversible upon stopping or reducing the drug. The good news is that severe muscle damage, a dangerous condition called rhabdomyolysis, is exceedingly rare.
How rare?
It occurs in less than 0.1% of patients, that's about 1 to 4 out of 10,000 people, even with intensive statin therapy.
Okay, so extremely unlikely.
Very unlikely. To put that in perspective, out of 10,000 people not taking statins, about 3 would develop severe muscle damage from other causes anyway. If all 10,000 took a statin, an average of only an additional 1 to 4 people might get severe muscle damage.
That's a helpful comparison. So if you do get muscle pain, what can be done?
Your doctor has several management options. They might first adjust the dose, as many side effects are dose-dependent. Alternatively, they might switch you to a different statin.
Because they're not all the same.
Correct. Their molecular structures vary, meaning one might be tolerated better than another. For example, common choices like atorvastatin, brand name Lipitor, and rosuvastatin, or Cruster, are very well studied. Pravastatin, which is a hydrophilic or water-loving statin, often has fewer drug interactions and may also be better tolerated in terms of muscle side effects for some individuals.
Okay, so switching is an option.
Yes, or trying alternate day dosing, or even a very low dose. Certain risk factors can also increase the likelihood of muscle pain. Untreated hypothyroidism, taking multiple medications, polypharmacy alcohol abuse, being female, age over 80, frailty, and conditions like chronic kidney disease or diabetes. Your doctor considers all this.
Got it. Okay, another concern that frequently comes up is the perceived link to new-onset type 2 diabetes. Do statins directly cause diabetes, or is it more complicated?
This is definitely a nuanced area. Statins can indeed increase the chance of developing new-onset type 2 diabetes, particularly with higher doses of more potent statins.
How much of an increase are we talking about?
On average, research suggests that about 1 in 200 to maybe 1 in 100 people might develop type 2 diabetes because they took a statin, typically after a few years of treatment.
Okay, so it's a real but relatively small risk.
It is. However, it's crucial to understand the context and the overall risk-benefit profile. For individuals who are already at a high risk for diabetes, maybe they have prediabetes, metabolic syndrome, or a strong family history, or, for those who do develop it, the statin's cardiovascular protective benefits.
Meaning the reduction in heart attack and stroke risk?
Exactly. Those benefits often far outweigh the small increased risk of developing diabetes. In fact, for a diabetic patient, the cardiovascular benefits of statins are particularly strong and well documented, making them essential therapy.
So the benefit usually outweighs the risk, especially if you're already high risk.
Generally, yes. It's also worth noting that not all statins carry the same risk. Pitavastatin, for example, commonly prescribed in Asian populations, hasn't been consistently associated with an increased risk of diabetes in studies. The current recommendation is always that patients should be informed of this potential risk, and routine monitoring of blood glucose levels is recommended during statin therapy, allowing for early detection and management if it occurs.
Okay, makes sense. What about other side effects beyond muscle pain and diabetes?
There are others, though generally less common or less severe and often transient. Liver function, for example. Elevated liver enzymes, transaminases, are observed in about 1–3% of patients, usually within the first 3 months.
Does that mean liver damage?
Not usually. These elevations are often dose-dependent, typically asymptomatic, meaning you wouldn't feel them, and they usually have little clinical significance, often resolving on their own, even with continued statin use. Cases of actual drug-induced hepatic failure are exceedingly rare, less than 1 in a million patients.
So routine liver tests aren't usually needed.
Generally not recommended unless specific symptoms arise, or if the patient has pre-existing liver disease. Then there are renal kidney effects. That severe muscle damage, rhabdomyolysis, can lead to acute kidney injury.
Because of the muscle breakdown products.
Exactly. Also, a benign proteinuria, small amounts of protein in the urine can occur, but its long-term significance is unknown and it usually resolves. While some studies suggest statins might protect kidney function, others show no reduction in proteinuria. There's a very slight transient risk of acute kidney injury observed, mainly in the first 4 months, with high-potency statins. But again, this is rare and monitored.
Okay. Now, there have certainly been past worries about cancer and statins circulating through various channels and causing considerable anxiety. What does the robust scientific evidence actually say about a link to malignancy? Has that concern held up?
This is a critical question, and the good news here is unequivocal. Large meta-analyses and long-term follow-up studies, some extending over many years, have consistently and definitively found no increased risk of malignancy with statin therapy.
That's really reassuring. No increased cancer risk.
None demonstrated. In fact, some studies have even suggested a slight reduction in the incidence of certain types of cancer, though this is an area of ongoing research and definitely not a primary reason to take a statin. So those long-standing concerns about statins causing cancer are not supported by the current extensive evidence base.
Great to hear. What about neurological effects? Dementia worries.
In terms of neurological concerns, while very rare case reports exist for peripheral neuropathy, nerve damage outside the brain spinal cord, subtle mood changes, and irritability, these are not consistently seen in large studies. Crucially, there is no good evidence that statins cause dementia, despite past concerns and a lot of misinformation.
So the dementia link isn't real.
The evidence doesn't support it. Many large observational studies and clinical trials have actually found no overall increased risk of dementia with long-term statin use, and some even suggest a potential protective role against cognitive decline, although that's still being investigated. Lastly, some individuals report gastrointestinal and sleep issues, things like constipation, diarrhea, feeling sick, headaches, or changes to sleep patterns. These are typically mild, often improve as the body adjusts, and are usually manageable.
Right, the usual adjustment period stuff.
Pretty much. Finally, it's vitally important for both patients and healthcare providers to be aware of drug interactions.
Ah, yes. How different drugs affect each other.
Exactly. Many statins are metabolized by a specific group of enzymes in the liver called the cytochrome P450 system, particularly the CYP3A4 isoform. Knowing these interactions can prevent complications.
Like the famous grapefruit juice warning.
That's the classic example. Grapefruit juice is a potent inhibitor of those CYP3A4 enzymes and can significantly increase the systemic exposure, the amount of drug in your body, and thus the risk of toxicity with certain statins like atorvastatin, Lipitor, lovastatin, and simvastatin. Patients on these are usually advised to strictly avoid grapefruit.
Okay, good to know. Any others?
1-fibrates, another class of lipid-lowering drugs, are combined with statins, particularly for mixed dyslipidemia, high triglycerides and low HDL. There's an associated increased risk of myopathy, muscle problems, up to 5%, which needs careful monitoring.
So combining those needs caution.
Yes. On the other hand, pravastatin, Pravachol, stands out because it's primarily metabolized by other pathways. This means it has the fewest drug interactions amongst the statins.
Ah, so that might be a better choice for people on lots of other meds.
It's definitely a consideration, yes, especially for patients on immunosuppressants post-transplant or HIV patients on protease inhibitors, where interaction risk is a major concern. This careful consideration of drug interactions is a key part of personalizing statin therapy.
So given all we've discussed about statins, what happens when there's simply not enough to get cholesterol levels to target? Or if someone genuinely can't tolerate them due to persistent side effects?
Right, what are the next steps?
Does the journey toward better heart health end there? Or is there a new frontier of options emerging that weren't even available a decade ago? It feels like we're really expanding the medical toolkit for heart health.
This is an incredibly exciting and rapidly advancing area of modern medicine, truly a new frontier in cardiovascular care. For individuals who experience difficult and persistent side effects from statins, or whose cholesterol levels remain stubbornly high even on maximal statin doses, there are now several effective alternatives and add-ons.
That's great news.
These offer tailored solutions, moving us further into the realm of precision medicine, ensuring that virtually every patient has viable options to manage their cholesterol.
Let's start with ezetimibe. How does this one work, and where does it fit into the broader picture of cholesterol management, especially when statins are either insufficient or, contraindicated?
Ezetimibe, often prescribed as a daily tablet, offers a mechanism of action that is distinctly different from statins, making it an excellent complementary therapy.
Oh, so different pathway.
Yes. Instead of inhibiting cholesterol production in the liver, ezetimibe primarily blocks the absorption of dietary and biliary cholesterol from the food you eat in your small intestine into your bloodstream.
Ah, so it works in the gut.
Primarily, yes. This reduction in cholesterol absorption then signals the liver to upregulate its LDL receptors and draw more cholesterol directly from your blood to produce new bile acids, which are needed for digestion. This leads to a further lowering of circulating blood cholesterol levels.
Okay, so less gets in and the liver pulls more out.
You got it. Alone, ezetimibe can reduce bad LDL cholesterol by about 15–22%. When taken in combination with a statin, it can add another significant reduction of 21–27% to the statin's effects, providing a powerful synergistic lowering of LDL.
So it can really boost the effect of a statin.
It can, and its side effects are generally mild and well-tolerated, often limited to some stomach pain or diarrhea, making it a valuable option for many, particularly those with statin intolerance or who just need that extra LDL lowering.
Okay, now this one, bempedoic acid, sounds quite new. Our sources say it only became available in the UK in 2021. What makes it different from statins and ezetimibe, and for whom is it typically considered?
Yes, bempedoic acid is a more recent addition to our therapeutic arsenal. It's taken daily, either as a standalone pill or in a fixed-dose combination with ezetimibe.
How does it work? Like a statin?
It's similar to statins in that it works by reducing cholesterol production in the liver, specifically by inhibiting an enzyme called ATP citrate lyase, which is upstream from the enzyme statins target.
Okay, earlier in the production line.
Exactly. However, a key and potentially beneficial difference is that bempedoic acid is a prodrug.
Prodrug, meaning?
Meaning it only becomes active in the liver. This liver-specific activation potentially leads to fewer systemic side effects like the muscle pain that can sometimes be associated with statins, as it largely bypasses muscle tissue.
So maybe less muscle pain risk.
That's the hope, and some evidence suggests that. On its own, bempedoic acid lowers LDL cholesterol by about 17–28%. When combined with ezetimibe, its effectiveness increases, providing around a 28% reduction, offering a statin-free pathway to significant LDL lowering for some.
Who is it mainly for?
NICE guidance in the UK suggests it's primarily for those who can't take statins due to unacceptable side effects, or when ezetimibe alone isn't sufficient. Potential side effects can include a slight increase in red blood cell count, an elevated risk of gout in predisposed individuals, and some pain in the hands, feet, arms, though generally less frequent than statin side effects.
Okay. Now, these PCSK9 inhibitors sound quite potent, and they have a different delivery method as well, right? An injection.
They are indeed quite potent and represent a significant leap in treatment, utilizing a fascinating biological pathway. PCSK9 inhibitors are given as an injection under the skin, typically every 2 to 4 weeks.
So not a daily pill.
Correct. Much less frequent dosing. Their mechanism is revolutionary. They work by targeting and inhibiting a protein called proprotein convertase subtilisin kexin type 9, or PCSK9.
Okay, what does PCSK9 normally do?
Normally, PCSK9 binds to LDL receptors on liver cells, leading to their degradation, meaning fewer receptors are available to clear LDL cholesterol from the blood. When PCSK9 is inhibited...
Stop that degradation.
Exactly. It prevents the degradation, allowing the liver to express significantly more LDL receptors on its surface. These abundant receptors then actively remove much more bad LDL cholesterol from the blood, leading to impressive reductions of up to 60%.
60%? Wow.
It's a big reduction. Crucially, for people with existing heart and circulatory diseases, large-scale studies have shown that these inhibitors can reduce the risk of death from a heart condition, heart attack, or stroke by a notable 20%, independent of statin use.
So they have proven outcome benefits, too.
Yeah.
Who gets these?
They are typically reserved for individuals who have already had a heart attack or stroke and whose cholesterol remains high despite maximal statin doses, or for those with a genetic condition called familial hypercholesterolemia, which causes very high cholesterol from birth.
And side effects.
Fortunately, reported side effects are few, such as mild flu-like symptoms or soreness around the injection site, making them generally well tolerated given their powerful effects.
Okay, and inclisiran, the gene silencing drug.
Yeah.
That sounds like something straight out of science fiction. An injection only twice a year.
It certainly uses cutting-edge technology and is indeed a profound glimpse into the future of precision medicine. Inclisiran utilizes a sophisticated approach called RNA interference, RNA therapy, to silence the gene responsible for producing the PCSK9 protein.
But instead of blocking the protein, it stops it from being made.
Exactly. Instead of just inhibiting the protein after it's made, like the PCSK9 inhibitors, inclisiran works upstream, preventing the liver from even making the PCSK9 protein in the first place. By blocking the production of this protein, it effectively boosts the liver's long-term ability to clear harmful LDL cholesterol from the blood.
And the dosing is really infrequent.
Remarkably infrequent, yes. It represents a paradigm shift in chronic disease management. After an initial dose, another 3 months later, and then only twice a year.
Incredible. How effective is it?
Clinical trials have shown it can reduce bad LDL cholesterol by up to 52%, providing sustained lowering. Like PCSK9 inhibitors, it's primarily prescribed for those who had a heart attack or stroke, and whose cholesterol isn't adequately lowered by statins or other conventional therapies.
Can it be used with statins?
Yes, it can be used alongside statins or other cholesterol-lowering drugs, but notably, it shouldn't be used with other PCSK9 inhibitors due to their similar mechanisms. Common side effects reported are generally localized, like pain, redness, or a rash at the injection site.
Okay, a whole new generation of treatments. Now, you mentioned earlier that statins can, for some people, reduce CoQ10 levels, potentially contributing to that common concern of muscle pain.
Yes, that connection is well established.
Is there a way to counteract that, perhaps with a targeted supplement? It sounds like a promising strategy to improve tolerance for people who need statins.
This is precisely where coenzyme Q10 or CoQ10 supplementation comes into play as a potential adjunct therapy for statin users.
Right, CoQ10.
Statins, while incredibly effective at lowering cholesterol, inhibit an enzyme in the mevalonate pathway, which is also involved in the body's natural production of CoQ10.
And CoQ10 is important for muscles.
Vital. Since CoQ10 is vital for mitochondrial energy production in all cells, particularly muscle cells, essentially, it helps your muscle cells generate power efficiently and also acts as a powerful antioxidant. Its deficiency is strongly theorized to contribute significantly to statin-induced muscle pain or myopathy.
So replacing it might help the pain. Is there evidence for that?
The evidence on this front is actually quite compelling and has gained traction in recent years. A systematic review of randomized controlled trials, specifically looking at CoQ10 supplementation, found that it significantly ameliorates statin-induced musculoskeletal symptoms.
Really? That sounds promising.
It is. Multiple well-designed studies using doses of 50 to 200 milligrams a day of CoQ10 showed consistent improvement in muscle complaints, pain scores, and overall muscle-related quality of life among statin users.
So it could genuinely help people stay on their statins.
That's the idea. This makes CoQ10 supplementation a highly plausible and increasingly recommended solution to improve patient adherence to life-saving statin therapy, especially for those struggling with muscle pain. Crucially, these studies reported no notable CoQ10 side effects, making it a safe and accessible option.
Good to know. Okay, what about natural remedies? There's a lot of chatter, particularly online, about things like garlic, green tea, red yeast rice, and other supplements for lowering cholesterol. Do they really work? And more importantly, can they replace prescription medication like statins?
Yes, the natural alternatives question. It's very common and important. Our sources do indeed touch on what are often called nutraceuticals foods or supplements believed to have health benefits beyond basic nutrition.
Right.
Compounds and extracts from things like bergamot, garlic, green tea, red yeast rice, omega-3 fatty acids, spirulina, soy proteins, lupin, and berberine have all been investigated in various studies for their potential cholesterol-lowering effects.
So there is some science behind them.
There is some, yes. While these natural remedies are generally considered safe with few adverse effects, and some have shown modest cholesterol-lowering benefits in certain populations, it's very important to understand their precise role and significant limitations.
Name of the limitations.
They're unequivocally not a replacement for statin therapy or other established prescription medications.
Okay, that's key, not a replacement.
Absolutely not. The evidence base for these nutraceuticals, while growing, is generally not as robust or consistent as the decades of data supporting statins in reducing hard cardiovascular events like heart attacks and strokes.
So they might lower numbers a bit, but don't have the proven track record for preventing events.
That's the main distinction. Experts suggest they may be useful as an addition to existing treatments for high-risk patients who need more incremental control over their cholesterol levels, or perhaps as a very cautious alternative for those who are truly statin intolerant and have limited other prescription treatment options.
So maybe a supportive role in specific cases.
Possibly. However, it's critical to emphasize that more comprehensive, large-scale, and rigorous research is still needed for clear, widespread recommendations on their standalone use or as primary therapy. Think of them as complementary tools that might offer a small edge rather than primary weapons in the fight against high cholesterol.
And always discuss with your doctor first.
Always. Especially because things like red yeast rice actually contain naturally occurring statins, so interactions and side effects are still possible, and the potency can vary wildly between brands.
So with all this comprehensive information, the intricacies of cholesterol itself, the profound power of lifestyle choices, the established effectiveness and detailed nuances of statins, and this exciting new world of alternatives and adjunct therapies. What's the single most important takeaway for someone considering any of these options for their own heart health? It truly feels like a lot to process and integrate into a personal plan.
It is a lot, and this raises an important question that brings our entire deep dive together. How do you integrate all this knowledge into a personal health plan that feels right, feels sustainable, and is truly yours?
Yeah. How do you make sense of it all for yourself?
The resounding, consistent message from all our sources is that managing cholesterol, especially when it comes to decisions around statins and other powerful medications, is always a shared decision.
Shared between you and your doctor.
Exactly. Your healthcare professional is not just there to tell you what to do, but to be your partner, your guide in this complex journey, navigating the evidence alongside you. It's about merging the best available science with your individual preferences and values.
It really comes down to your individual situation, your comfort level, your personal risk tolerance, and what matters most to you in terms of your health and quality of life.
That's it, precisely.
It's about finding that sweet spot where robust science meets your personal values and priorities, creating a treatment path that you feel truly confident about.
Exactly. You should feel completely empowered and equipped to discuss the rationale behind any recommendation your doctor makes, whether it's for a specific lifestyle modification, a statin, or one of the newer medications.
So don't be afraid to ask questions.
Never. This means understanding your specific, personalized risks and benefits. perhaps reviewing your QR-ISK score together and discussing what that percentage truly means for your personal future, weighing those known, scientifically proven benefits against any potential risks or side effects that are significant to you.
Because what matters to one person might not matter as much to another.
Absolutely. It's about being clear on which benefits and risks matter most to you in the context of your overall health, your daily life, and your long-term goals. For instance, some people might prioritize avoiding even a low risk of a particular side effect, even if it means a slightly higher residual cardiovascular risk, while others might prioritize maximizing risk reduction at all costs, even with minor discomfort. Your doctor should facilitate this nuanced conversation.
So what are some good questions people can ask their doctor?
To help you facilitate this crucial dialogue and make the most of your appointments, here are some key questions you should feel comfortable asking, armed with the knowledge from today's Deep Dive.
Okay, let's hear them.
First, given my unique health profile, my family history, and my current lab results, what's the specific rationale for recommending or not recommending a statin for me right now?
Get the why.
Exactly. Second, can we review my personal QR-ISK score or ASCVD risk estimator score together? What are my specific overall cardiovascular risk factors that might not be captured in the calculation, like that strong family history we talked about?
Understand your personal risk.
Third, what are the most likely side effects I might experience with this particular medication based on my health history? And, crucially, how would we manage them if they occur, for example, with dose adjustments or switching to a different type?
Plan for potential issues.
Fourth, beyond medication, what concrete, evidence-based lifestyle changes can I make alongside or instead of medication to further reduce my risk? What resources or support are available for those changes, like dietary counseling or exercise programs?
Focus on lifestyle too.
And fifth, if I genuinely can't tolerate a statin or if my cholesterol levels aren't adequately lowered by them, what are my alternative medication or supplement options, such as ezetimibe, bempedoic acid, PCSK9 inhibitors, or inclisiran? How do they compare in terms of efficacy, side effects, and how do they fit into my specific situation?
Know the backup plan. Those are great questions. Remember, it's your body, your choices, and your health journey.
Absolutely.
This isn't a one-and-done decision. Your health and the scientific understanding of these conditions are always evolving. So you should feel empowered to revisit your decisions with your healthcare team as your health status changes or as new research emerges.
That's right. It's an ongoing conversation.
The ultimate goal is an informed decision that you feel confident about, one that supports your long-term well-being. Hashtag outro.
Wow, we've truly covered a vast landscape today, journeying from the nitty-gritty of cholesterol itself, separating the good from the bad, and understanding its essential role, to the incredible, often underestimated power of your daily choices in shaping your heart's future.
We covered a lot of ground.
We've taken a deep dive into the latest on medications like statins, critically debunking common myths about their side effects with real data, and explored a truly exciting new frontier of alternatives and adjunct therapies like PCSK9 inhibitors, inclisiran, and the potential role of CoQ10.
It's abundantly clear that understanding your heart health is a multifaceted journey, and you now have more tools, more nuanced knowledge, and more agency at your disposal than ever before to navigate it successfully.
Indeed. We've seen how robust lifestyle changes form the bedrock of cardiovascular health, providing benefits that permeate every aspect of well-being.
The foundation, really.
Absolutely. We've explored how statins offer proven, powerful, and reproducible protection against heart attack and stroke, and critically, how to navigate their potential side effects by understanding their true incidence and effective management.
Getting past the hype.
Exactly. And beyond statins, we've illuminated how a growing array of cutting-edge alternatives and specific supplements can offer tailored solutions for individuals based on their unique needs, tolerances, and risk profiles. The journey from confusion to empowerment is paved with knowledge.
Your heart's been beating for you tirelessly since day one.
Yep.
Maybe it's time you do a little something extra for it, too. What specific nugget of knowledge stands out most to you from today's deep dive? How will you take the next step in becoming an even more informed and proactive advocate for your own health? Whether it's by adding some soluble fiber to your diet, taking that brisk walk, or having that crucial, empowered conversation with your doctor about your options.
Consider this. Knowledge isn't just power, it's also the most reliable path to genuine empowerment. Keep learning, keep asking insightful questions, and keep connecting with your healthcare team. This proactive engagement will ensure your heart continues to serve you well for years and indeed decades to come.